I'm Dr. Mia Paquin, and welcome back to the Dr. Mia Paquin podcast. I'm here with Dr. Ken Abrams, who is one of the clinical psychologists at Psychology Express, but also on faculty at Carleton College. And today we're going to be talking about some interesting topics, including virtual reality and how that relates to mental health. Tell us a little bit about your background in psychology, virtual reality.
Sure. So my day job is I'm on the faculty, as you mentioned, at Carleton College in the psychology department. And so I teach courses there in psychopathology and health psychology and statistics. And I also do research on campus with students, and typically in the areas of addiction and anxiety disorders and trauma. But then I also do clinical work for Psychology Express and tend to also specialize in anxiety disorders and addiction within my practice.
So lots of experience drawing from academia, research, clinical work. And how did you get to this point? Like, what did you have to do to get to this point in your career?
Sure. Well, I went to graduate school at the University of Minnesota, and so pursued my degree, my PhD in clinical psychology there. And then afterwards, I had a couple of visiting faculty positions at University of Richmond and at Reed College before ending up with a tenure track position at Carleton in 2008. So I've been there for about 15, 16 years now, and was the department chair for a few years, and now passed that on to someone else.
And spring break is just around the corner here for you and the students, but you'll be doing some work probably during that time.
Spring break for faculty is oftentimes planning for the upcoming term. So we have a spring trimester that will start at the beginning of April.
Okay. Well, kind of a misnomer then, not really a break for you, but I'm sure the students appreciate it. Well, as we get going here, today we're going to talk about virtual reality. And one of the things I wanted to ask you is, what is out there right now?
There's not a lot of clients who are actively seeking this. They may not even know about this, but this is something that clinicians are starting to become more aware of through articles and journal articles. You're more likely to see it or have it sought out within the VA system for people with PTSD, but I wouldn't say a lot of clients have started to seek this out yet. Let's use the example of exposure therapy for a phobia. So the client would wear a VR headset and be placed into a virtual world, and within that world they might be exposed to stimuli that cause them to experience high levels of anxiety, perhaps panicky symptoms. And with virtual reality, the specific stimuli can be tailored for that individual. So for example, for a person who fears dogs or flying or heights, these are all things that a person can be safely exposed to within a clinical office without having to travel to a specific spot to find these particular stimuli.
Having to imagine the dog or being on the plane yourself are going away, and soon you can just do that in a virtual reality.
Yeah.
How fascinating. And so this is true for phobias.
Mm-hmm.
Are there other disorders that people are using virtual reality or researching virtual reality therapies for?
There's a related condition, post-traumatic stress disorder, in which individuals are being exposed who have experienced trauma, for example, through combat, to stimuli that often will provoke their anxiety. So as an example, individuals who are, say, U.S. service persons who return from Iraq, they can be placed into a virtual world that simulates situations that they experienced in Iraq. And we know that exposure therapy, exposing people to what they fear for extended periods, can be therapeutic. In this particular case, the therapist oftentimes has control over the specific scenario that the client will see in VR. So they can, for example, tailor the experience to reflect whether there was a dust storm at the time of the incident that caused the trauma. They can change the time of day. They can change how many people were present, whether there's buildings around or not. And so the more control that the therapist has over the situation, the more realistic it becomes in the eye of the client, and therefore the more therapeutic it can be with respect to exposing individuals to stimuli that would ordinarily provoke a lot of anxiety for them.
Wow. Okay. So during this, the psychologist is kind of adjusting the virtual world to either increase or decrease anxiety. And are there like physiological measures? Like, is there biofeedback measures or blood pressure, pulse rate, things that they're looking at?
So most of this is from research rather than clinical settings, but in research settings, absolutely. So it will often be the case that individuals who are undergoing these trial treatments for exposure therapy will wear pulse oximeter, which also indicates heart rate, and they'll be asked to periodically state their subjective level of anxiety. They fill out questionnaires before and after the exposure therapy session. So from a research perspective, the individual is giving a lot of data to the researcher to help determine whether or not this is an effective approach.
There's a lot of research going on in this, including your own research.
That's right.
Yeah, talk to us a little bit about what you're doing.
So we know that for individuals who have developed PTSD, there's effective treatments. We just discussed exposure therapy, for example, as one option. And there also are some things that can be effective before a person is deployed into a high-risk scenario and before they actually experience a traumatic event. So there's some inoculation training that can be done for example, combat troops before deployment. There's very little research and very little that's been found to be effective for individuals in this time window between when the traumatic event occurs and when they develop PTSD. My lab focuses on that small window, which is to say, can we prevent PTSD among these individuals who have recently been exposed to traumatic events? Of course, we don't expose people to actual traumatic events, but what we do is we use something called the trauma film paradigm. And so we put people into virtual worlds, and we have them watch very frightening film clips, things that most people would find disturbing, but not traumatizing, more frightening or disturbing. We're not really inducing, of course, PTSD. And then we try out various interventions just after this exposure to these frightening films. And we can talk about the types of interventions that we try out. And ultimately what we do is we look at how do these interventions affect the frequency of intrusive memories from these frightening films over the subsequent week. Is there a way that we can do something afterwards that will decrease the likelihood that a person will regularly experience intrusive, perhaps disturbing memories for the next week? And notably, we're trying to interfere with the affective component of this. So we're not trying to erase the memory. Mm-hmm. We're not trying to prevent a person from recalling the facts of what they experienced. Yeah. And this is important because we don't want that person to experience PTSD. We don't want them to be having involuntary intrusive memories that cause them such fright. Right. And so we'd like to remove the negative psychological toll in the person. On the other hand, we want them to be able to recall the facts in the event they need to testify in trial against a perpetrator. And so we're trying to affect the consolidation of the memory, but in a way that primarily decreases the chances of having this negative affective response to what they experienced. There's some initial thought that there's about a 6-hour window following a trauma in which memories tend to consolidate, and so that might be the primary window of intervention. There's some other research that says that even once the memory is consolidated, even days later, it can be reconjured into memory and altered and then reconsolidated in a way that's therapeutic. So we don't know about the exact windows yet for when this happens, but we imagine that the sooner, the better. And so with that in mind, we imagine that first responders and those who work in emergency room settings, individuals who are combat medics, right, would be the most likely to be able to employ these techniques.
Are there opportunities, with these, virtual reality preventions to be able to insert, different types of healthy cognitions, mm-hmm. healthy thoughts, rather than, detrimental thoughts people might have, such as self-blame or feeling like they should have acted differently, survivor's remorse, that sort of thing.
Yeah, so that's an interesting question, whether, in a sense, cognitive therapy could be employed before the actual psychiatric disorder like PTSD develops. And there isn't really research on that so far. The research that I've seen and the research that we're doing really focuses on just affecting the memory rather than having a person directly address, for example, irrational thoughts.
Okay.
Certainly, as you know, after a person develops PTSD, a very common treatment is to have a person express their sentiments about what the traumatic event itself, as well as their thoughts about frightening things they're afraid to do, and to examine those to see if those are rational thoughts or if they're exaggerated.
Well, this is exciting to see where the field is going. Exposure response prevention, which is a type of therapy we use for OCD. Can you also give us some examples? What might that look like if we were working with someone with that disorder?
I've only seen 1 or 2 studies on this, but we can still imagine how it could be used. So, for example, a person who could be taught without virtual reality to employ cognitive behavioral therapy to deal more effectively when tempted, when feeling the urge to engage in compulsive behaviors. For example, flipping light switches or checking to see if a stove is, repeatedly to check if a stove is on, or leaving one's house and repeatedly checking and returning to make sure that the front door is locked. So we can put individuals in virtual worlds in which we test, in a sense, within the clinical office, their ability to engage with these, again, stimulating, like light switches or doorknobs, to see if they're able to effectively employ their new skills in that setting. So there was one study, for example, that created a world in which people would walk through this house and they would frequently pass light switches and have to turn doorknobs and so forth. And so they were examining the extent to which previous therapeutic intervention would have an impact on a person's ability to avoid these compulsive urges. There's a number of studies that have looked at skills training for virtual reality. So individuals, for example, who might benefit from social skills training. Sometimes individuals with autism, sometimes this has been also employed in individuals who are diagnosed with schizophrenia, who are put into virtual worlds and asked to try out some social skills that they have previously been taught within the client therapist setting. Another option that I saw, and I thought this one was interesting, another condition which has been addressed through virtual reality was substance use disorder. So again, there was a pilot study done that had individuals with substance use issues enter a virtual world, and they were looked within the virtual world at pictures of themselves. Except these pictures of themselves were AI was used to project how they might look if they spend 20 years on a path continuing to use a substance, for example, methamphetamine, and so how they would age if they were to stay on this path versus how they might age if they were to remain abstinent for those 20 years. And so they saw the difference between how the AI projected they would look, and that they measured as an outcome abstinence levels over the ensuing weeks, and they found that it did drop. But this was a small study, but it did drop for individuals if they were exposed to pictures of themselves that were aged as if they were going to continue on the substance.
Right, kind of like, the looking glass mirror. Here's what you're going to look like in the future if you continue to use. Certainly a motivating factor for people as they're trying to reduce or quit. I know in my own work, historically, we would have these little kits that we would use for cue exposure with people with addictions, with, syringes or, fake drugs or substances, alcohol. And we would have clients exposed to it to kind of decrease their cravings. And I can only imagine there's even greater opportunities now as virtual reality therapies come out.
One could put a client into a virtual world, for example, into a casino environment, into a bar environment, and ask them to employ skills, ask them to employ skills that they've been taught with the client by the therapist, such as cognitive reframing, but also, as you mentioned, these type of situations can evoke an urge to engage in the behavior, whether it's gambling, whether it's drinking alcohol, for example. And so we can both have them endure being in a situation without use. We can have them employ some of the skills, but I do think that exposure to situations that provoke an urge to engage in a, say, unhealthy behavior would be another potential use for VR.
Are there ways, just in general, that you can see virtual reality changing how we do therapy, telehealth, other things like that?
The quality and the realism of VR is going to continue to improve. Also, we imagine that the price will continue to drop. And at some point, we might reach a point where many people have virtual reality in their homes. Right now, it's not so common. It's primarily, let's say, teenagers who use it for gaming purposes. But as the price drops, we can imagine individuals, a therapist in their office, a client in their home, both donning virtual reality headsets and meeting, quote unquote, in a virtual office to conduct what might feel like one-on-one in-person therapy.
During COVID, obviously, lots of telehealth and people's comfort level with that increased. But now we see a lot of folks who call us and do want that in person. Mm-hmm. But if we were able to, virtually kind of see the other person, not just, their head, or have kind of a virtual therapy room where we're seated together, would that enhance the experience?
So as the technology continues to improve, I'm sure some people will do studies to examine how therapeutic is it to be in this combined virtual room with one's therapist.
Certainly working with kids or people who are very active need to move around the therapy room, not being able to have to sit right in front of that monitor might also, make telehealth more available to some of these other clients who right now need to come into the office. Is there any potential drawbacks that you can see? Anything where you feel like, we need to be cautious?
For individuals who have a history of motion sickness, being in a virtual world can actually induce motion sickness. So we screen potential participants for this. And it's also the case that an individual might experience a much stronger anxiety or panic reaction to a stimulus. So there may be some drawbacks to not being present with that client while they're experiencing this. But generally, we don't see a lot of, I don't think there's a lot of concerns in terms of side effects, in terms of medical or psychiatric concerns. I really think at this point the main concern is the availability of VR headsets, the price of them, for example, for clients, and the technology.
Wow. It's going to change, the field of psychology, how we deliver services, probably also how we train as psychologists, right? So, essentially having more ability to have supervisors be involved, maybe experts from across the country involved in exposure response prevention or something like that.
Right now, everything that we're doing, there's others who have examined this approach as well. There's a small number of labs that are examining this tiny window in there. It's really not employed at all in the field at this point. In fact, the only thing that we see sometimes employed in this intervening window between the traumatic event and the development of PTSD is something called critical incident stress debriefing. And this is something that is sometimes popular as a means of preventing trauma, but almost all of the literature shows it to be either ineffective in preventing PTSD or to actually increase the risk of this. So I'm interested in seeing both studies and clinical work where some of the things that we're looking at leave the laboratory setting and are employed in real world settings. There's been a couple small studies where in my area, where groups have looked at the extent to which employing some of this technology that can, in theory, prevent PTSD is useful among recent car accident victims. So they actually did some research in a emergency room setting. There's some other research that employ these same types of approaches for women who experienced emergency C-section deliveries. And so we're starting to see a few studies where it's leaving the lab and entering the real world, but still at the very beginning of that process.
Well, I want to thank you, Ken. You are always a pleasure and so interesting to talk with. I know that, all of our staff love to just kind of drag you and ask you questions about your research and what's going on, so I'm glad we're able to share it with others. You have so much expertise and knowledge, and I mean, it's rare where somebody can wear all three hats of academics, research, and clinical work, and you do it amazingly. So thank you.
You're too kind. It's a pleasure to chat with you as well.
Thank you for watching today's episode with Dr. Ken Abrams. Remember to like, comment, and subscribe. Betty and I will see you next time.